Good evening, and thank you for joining us at Building Strength Webinars. This is Dr. Katherine Neubauer here to speak with you tonight regarding antioxidants and chemotherapy. And I would like to thank Dr. David and Sherry for the invitation to speak with you tonight, and I really appreciate the business that they have reaching out to people all over the world who are interested in building up their health and wellness and strength. Dr. David asked me to speak with you tonight regarding a practical approach to building up your health while going through chemotherapy treatment. And this is something that may be relevant to you perhaps because you're currently actively receiving treatment as a cancer patient, or perhaps you have a loved one or family member who's walking on that journey, or you may be of interest to you because you're involved in the health and wellness business and you're reaching out to patients or clients who are in that circumstance, and perhaps you're wondering with the current antioxidant products that you work with how to share those safely and effectively with people who are going through cancer care. And so those are all questions and situations that we'll speak to tonight. A little bit about me. My doctorate is in naturopathic medicine from the Southwest College of Naturopathic Medicine in Arizona, and I currently practice in naturopathic oncology at New Path to Health in Tulsa, Oklahoma. So regarding tonight's program, the goals of our program will include discussing the controversy, the benefits, and the risks surrounding combining antioxidants and chemotherapy. And we'll also talk about how to safely and effectively use antioxidants as part of cancer care. Throughout this, I'll give you tools to help you communicate about antioxidants with your oncology team if you or a loved one are presently receiving care. And also help you to discover the benefits of naturopathic oncology care, and particularly to understand when professional consult is indicated. And in doing that, I'd like to talk with you a little bit about naturopathic oncology and the services that are available to people through that. And what naturopathic oncologists do is offer practical integrative care for people living with cancer. And we do that being rooted in the healing power of nature and the principles of naturopathic medicine. And when I speak of the healing power of nature, I mean that we as naturopathic doctors firmly know and believe that the body is able to heal itself given the right tools, and that the natural world helps us with those tools as well. And some of those principles of naturopathic medicine, one of the core principles that we'll look at tonight in Latin is called docere, which means doctor as teacher, and that really is the root of the word doctor. And so tonight what I'll be doing is teaching you some valuable tools to help you on your cancer care journey. This presentation, like all presentations on Building Strength webinars, is focused on teaching you and empowering you with tools for success. That goal is, of course, educational and does not replace the medical care that you may need to seek at some point in your journey. And wanted to speak a little bit in introduction about why we're talking about cancer tonight. Many of my patients ask that perhaps they work in the health industry currently and they wonder, well, they're very familiar with antioxidants and healthy cell biology and all the things that antioxidants can do for them. And so they wonder why it is that we need to talk specifically about cancer and antioxidants. And so I'd like to share with you that cancer cell biology is different from healthy cell biology. There are certainly a lot of things that we can learn and understand about cancers based on understanding healthy cells, and there are also some unique features. In fact, there'll be some pieces of information that I'll share tonight that I think you'll find shocking or surprising, particularly as relates, for example, to green tea or to glutathione. And the reason that those things are different in cancer is that if a cancer cell acted biologically like a normal cell, it wouldn't be cancer. Some of the core functions of cancer cells involve changing or tricking basic body biology. And so natural medicines behave differently in cancer cells than they do in normal cells. And what we know about healthy cells and even about cancer prevention in healthy people doesn't always apply in cancer cells. And so first off, I'd like to talk a little bit about antioxidants, and I'm sure that many of our audience members tonight are quite familiar with them, but wanted to start by basically defining some terms. And so an antioxidant is something that helps to stop the cellular rust that happens to all of us involving reactions with oxygen. And those chemical reactions are essential to our living and literally our breathing, because we take in oxygen through the lungs and then that goes through oxidative processes. It's also essential to the cellular metabolism that happens in our liver to feed and nourish us. And so antioxidants help us by quenching the free radicals that are produced through those oxygen reactions. And this is just a little bit of humor to illustrate the concept of free radicals. We've got antioxidant kicking out the free radicals for us there. And so when we talk about antioxidants, I think there'll be some pieces that'll be very familiar to you and some that hopefully will be new and interesting. Familiar ones would include what we call the usual suspects, so vitamins E and C and K, beta-carotene, selenium, glutathione, and our colorful fruits and veggies, our rainbow of the greens and reds and blues and oranges and yellows in our foods. And regarding then some surprise contenders as far as antioxidants, this lady here is enjoying a bath in dark chocolate, a delicious way to celebrate antioxidants. Some other ones that may surprise you may be melatonin, folate from the B vitamin family, CoQ10, green tea, the herb turmeric, coffee, alpha-lipoic acid, and the herb milk thistle. And so when I speak tonight of antioxidants and chemotherapy, I'm going to touch on a variety of these, that is, exploring some of the traditional antioxidant nutrients like vitamin E and C, but also probing into some of these special nutrients like melatonin and glutathione, and even into some of the herbs. And so to start off with, I'd like to talk about the evidence regarding the benefits of antioxidants in chemotherapy. And there are very clearly several with good evidence that you can share these with your family and your oncologist. And these benefits include anti-cancer effects in certain situations, ability to improve certain chemotherapy outcomes. You'll notice that I'm using the word certain because we have to be very specific in the field of naturopathic oncology. So things can be true for a given cancer type and chemotherapy regimen and might not be true for another situation. Some other benefits of antioxidants can include decreasing some side effects of chemotherapy, protecting healthy tissue DNA, and potentially increasing what we call chemotherapy dose intensity. And I'll talk a little bit more about what that means and how it can make a difference in your care. So first of all, talking about anti-cancer benefits of antioxidants, many of my patients are quite familiar with the role of antioxidants in cancer prevention. For example, there was a large population study that looked at fish oil and found a 32% risk decrease of developing breast cancer with the use of fish oil. And so actually there's an error in that slide. I'll have to correct that. It should be a 30% risk reduction. And then some things that often people are less familiar with. For example, with a chronic form of leukemia, green tea can actually stabilize that disease. And that was found in a phase 2 clinical study this year. And then some other new information has been regarding cancer stem cells. They're thought to be the precursors of cancer and the primary drivers on why cancer recurs and grows despite chemotherapy and radiation. And it's been found that sulforaphane from cruciferous vegetables targets these cancer stem cells in some of our more aggressive cancers like pancreatic and breast cancer. And so that's very exciting news. And then regarding improving outcomes, this is an excellent review that was done by the Simone family, and it's a great study to be able to share with your primary care physician or oncologist when discussing your care. And I'm going to go in some detail on the next few slides regarding their findings. And what they did is an extensive review of studies regarding antioxidants and chemotherapy, looking for both benefits and harms. And what they found were several pieces of good news. These 3 clippings show you 3 different clinical trials that were done looking at the impact of vitamin A on cancer outcomes in conditions as diverse as metastatic breast cancer, non-small cell lung cancer, and a form of chronic leukemia. And so I'd encourage you, when you have a moment, to delve into those and really look at those results. They're quite impressive. Furthermore, regarding improving outcomes, melatonin, which is made by the brain's pineal gland, has extensive research regarding improving outcomes in a variety of what we call solid tumors. Those are the non-blood-borne tumors, so a breast cancer, a lung cancer are all solid tumors. And this particular study clipping looked at two populations of people with lung cancer and found that when those individuals were given melatonin along with their chemotherapies, that they did better in terms of response to the treatment and in terms of their survival. And the second diagram that I have for you up at the top here, I'm drawing an arrow for you here. Give me just a moment. So this diagram here shows a little bit about melatonin biology. And what is of interest there is ways in which melatonin is acting beyond its antioxidant function. And so you can see there that it's acting on cytokines and interleukins, and so it has some immune system effects going on. And so this is of interest, that some antioxidants improve outcomes for cancer patients in ways that go beyond their activity as an antioxidant. And we'll explore this theme further as well when we look at some of the concerns regarding interactions, that antioxidants can have interactions not only by being antioxidants, but through their other forms of activity. Regarding decreasing side effects, there's also quite a bit of good news there. These three studies all looked at the use of vitamin E in the form of alpha-tocopherol in a variety of cancer conditions. There's one randomized study and two observational studies here. And this is, again, all coming out of the Simone paper, so that you can look there for further details. And they found beneficial effects in, for example, decreasing mucositis. Mucositis is a very painful condition of the mouth in which people develop mouth sores. And in addition to being uncomfortable, it can also affect outcomes in two ways. One is it can be what we call dose limiting. That means that people become so sick from a side effect that the dose of chemotherapy has to be reduced. And when that happens, often we see less effect from the chemotherapy. The other thing about mucositis is that it can limit people's ability to eat. And as you can imagine, for folks who have who are already very ill and fighting cancer, loss of body weight can be critical in terms of their outcomes. And it's found that for every 5% weight loss that a cancer patient has, that there are significant decreases in their survival, regardless of the treatment that they receive. And so keeping weight and eating happening for people undergoing cancer treatment is very important. And then we talked a little bit about increasing effective dose, and I want to go into more depth on that. That is to speak to the fact that decreasing side effects in chemotherapy using natural medicines can actually affect outcomes and the effectiveness of the chemotherapy. And that's because chemotherapies are usually most effective at their maximally tolerated dose. And when we talk about dose intensity there, that relates to two things. One is the amount of the dose given, and the other is the time period in which it's given. So for example, a chemotherapy might be scheduled to be given one treatment every 3 weeks for a total of 5 treatments. And if there are any delays so that that 3-week treatment has to become a 4-week or a 5-week treatment, it becomes less effective. The tumor cells have more opportunity to multiply. And so side effects can limit dose intensity, leading to dose reduction and to delay. And so if we decrease side effects, we can increase the dose intensity and potentially increase the effectiveness of cancer therapy. And this study looked at increasing the effective dose in relation to the antioxidant vitamin E and a very rigorous form of chemotherapy for metastatic breast cancer involving 3 drugs: cyclophosphamide, adriamycin, and 5-fluorouracil. And what they found was that vitamin E did not decrease the anti-tumor effect of the chemotherapy, and that through potentially protection of the heart, that additional adriamycin was able to be given in a significant amount. And they found this by looking at actually biopsies of the heart in these patients. And for adriamycin, toxicity to the heart is what limits the total amount of dose and therefore the effectiveness of the drug that can be given. And anything that can protect the heart then is desirable. In a related note, another antioxidant that has similarly been found to protect the heart with adriamycin is CoQ10. So we talked then about several of the benefits of using antioxidants with chemotherapy. We talked about increasing the effective dose and decreasing side effects. We talked about anti-cancer effects as well as protecting normal tissue DNA. Now I want to talk about some of the concerns. We need to be familiar with these for a variety of reasons. One is that they are very valid concerns and things that we'll want to address in care planning. Secondly, is that there may be things that your oncologist or primary care physician is concerned about when you speak to them about antioxidants, and that it may be beneficial in terms of communication with your care team to understand these issues. And so some of the concerns that we'll discuss are, one, the concern that antioxidants may decrease the oxidative efficacy of chemotherapy. This is the number one concern that I hear from my patients' oncologists. And so there's a conversation about the fact that certain chemotherapy medicines act by oxidizing, by generating free radicals that damage tumor DNA. And there's a concern that giving an antioxidant concurrently could then decrease the effect of chemotherapy. In certain situations, this is a very valid concern, and in other situations, it's something that may not apply or that we can work around, and so we're going to talk about a solutions-oriented approach to this issue. Secondly, there's the concern that antioxidants may promote tumor development, and in certain situations, that's true. In certain situations, the data is just not founded. And we'll talk a little bit more about that. The next question is, the next concern is that the data are hard to interpret. And in that situation, I think physicians can take a couple of different approaches. And one approach is to dig deeper into the data and really work to understand it. And the other approach is to recommend against the use of antioxidants until the data are clear. And so certainly some oncologists will choose to recommend against the use of antioxidants for that reason, or even recommend against the use of all supplements for that reason. That's where naturopathic oncologists can really step in and help patients taking the time and the research to investigate these issues and guide patients using the data that we do have, because there is much of value to be had from antioxidants and supplements, and we certainly wouldn't want to leave that behind for our patients. Next, we want to we'll look at the concerns regarding the possibility that antioxidants could interact with chemotherapy through non-antioxidant mechanisms. And so when we talked about melatonin, we discussed the fact, for example, that melatonin has beneficial interactions for cancer patients that stretch above and beyond its antioxidant mechanisms. So similarly, we can also have negative interactions that way, and it's important that we understand those, and we'll go in depth on a few examples of those tonight. So going into greater depth on some of these concerns. The first concern is regarding the oxidative efficacy of chemotherapy. We talked about the role of free radical generation in damaging tumor DNA and the effects of chemotherapy. Pardon me, I'm just going to, so I skipped on the slides here, and I'll get us back in place. Give me just a moment. Okay, so we're back in place now, and so discussing the concern regarding the oxidative efficacy of chemotherapy. And it's true that some chemotherapies do act primarily via free radical generation to produce DNA damage, and so we would want to hold the antioxidant away from that chemotherapy. Now, the good news we'll talk about when we reach the solutions conversation of this talk. We have several pieces of good news. One is that the set of chemotherapies that act primarily via this mechanism are limited. And so there's only certain chemotherapies that we need to be concerned about here, and that's where a bit of knowledge is very empowering. Secondly is the time duration of this effect is fairly short, and so for a brief time and using a little bit of knowledge, holding our antioxidants away from those specific chemotherapies, we can avoid harm and also continue to enjoy the benefits of the antioxidant. The next concern is that antioxidants may promote tumor development in certain situations. And we've all opened up the paper and read those articles about how, beta-carotene is killing people with lung cancer, or folate is very bad if you have colon cancer. And I want to go into those in a little bit more depth and really understand what's going on there. And so the first piece I want to talk about is antioxidants and smoking. And I really like this picture set because I see this so often in patients that they start out on the left smoking and then come to a point in their life where they'd like to increase their health and they begin taking supplements, and then they become like the lady on the right who's really focusing on taking care of herself and taking her supplements. But sometimes in educating my patients, we have to talk about the fact that that whole set of pictures affects their biology, and so the supplements that they're taking on the right are going to behave differently in their bodies under the context of somebody who's, say, smoked for 40 years beforehand than they would in somebody who'd never smoked. So we don't get to completely wipe the slate clean simply by taking supplements, and also we have to be prudent about which supplements we give a smoker. And particularly with beta-carotene, which you see those pills in the middle picture there, I would strongly encourage cautious use or even no use of supplemental concentrated beta-carotene in current and former smokers. Certainly smokers can enjoy the benefits of beta-carotene through their colorful whole foods. And so why the concern with beta-carotene in smokers? Well, there was a large randomized trial done with patients with head and neck cancers. Those are cancers, for example, like laryngeal cancer, parotid gland cancer. And these people received radiation, which is a standard treatment. And what they found was that in a subset of the people in the trial who were current smokers, that means they were actively smoking while going to radiation therapy, those people who received beta-carotene, two bad things happened. One, they developed more new cancers. That is, not just a spread of their current head and neck cancer, but a whole brand new different kind of cancer. And when these people were followed for 7 years after the initial dosing of the beta-carotene, these people died sooner than other trial participants. So this is very sobering data. And so there are a couple of different ways that physicians interpret this data. Certainly the most circumscribed thing to say would be, if we were taking it literally from the study, we would say that current smokers who have head and neck cancer and are receiving radiation should not take beta-carotene during their radiation. That would be the most narrow definition. The broadest definition would be to say that smokers should really consider getting their beta-carotene and perhaps certain other antioxidants primarily from their food rather than pills. And you'll find it, talking in the physician community, interpretations that go through that whole range. Secondly, I want to talk about the special case of folate in colon cancer. Folate's a very interesting nutrient. It's widely available through our foods, particularly our whole grains and nuts, and it acts as an antioxidant. It also acts as an essential component of DNA replication, and so tissues that are injured and healing use quite a bit of folate. And there's interesting research in colon cancer in particular that kind of cancer essentially develops as an unhealed wound. So when there's continual inflammation in the colon, a colon polyp can develop, and then that polyp can, through many years and many inflammatory insults, progress to cancer. And so, as you can imagine, as that tissue is inflamed and trying to heal itself, it will use folate. And then as that inflamed tissue progresses to a precancerous lesion called a dysplastic lesion, and then onto a cancer, it will continue to use folate as well. And so it is certainly of interest to look at folate in colon cancer. And we have this first study, which was a randomized prevention trial, looked at people who had a history of colon cancer. The tumors had been surgically removed, and then the patients were actively monitored through colonoscopy. And it was found that those patients who were given a fairly high dose of folic acid, 5 milligrams, which is a very large dose compared to, for example, the microgram doses you get in a prenatal vitamin, that these people who were followed did have decreased rates of recurrence of their colon cancer. And so that was very good news and would encourage us to consider using folate as a chemopreventive antioxidant. However, we then get to this next study, an animal study, and they looked at, in mice who were given folate, they looked at its impact on colon cancer. And an interesting thing happened, which was that in mice who did not currently have colon cancer, having plenty of folate was preventive of cancer. And in mice who already had the colon cancers in their guts and they were not surgically removed, the folate actually fed the cancer. And so what these two studies put together suggests, perhaps, is that folate may feed the development of both kinds of cells, both the healthy colon cells and the tumor colon cells, and that for that reason that giving supplemental folate in particular may be a prudent thing to do in chemoprevention if we know somebody's had a good colonoscopy, there's no problems, but that we may be very cautious about giving folate to somebody who currently has colon cancer or is at high risk for developing it. Certainly, though, the interpretation of these two studies is a subject of active debate among oncologists currently. So those two issues, the one of smoking and beta-carotene and the one of folate and colon cancer, give you, I think, at least a little taste of some of the challenges we encounter when trying to answer questions about antioxidants and chemotherapy, particularly when there are activities that extend beyond those of simple antioxidant behavior. The next concern I want to talk about is one of data interpretation. And of course, every time on the news you see a new study about natural medicine and cancer, the response at the end is always more research is needed, which is maybe a little bit of a cop-out, but also quite true. That is that there's always more answers than more questions than answers when it comes to cancer care. And so certainly some physicians will look at the data and say, well, it's incomplete or it's hard to interpret, so I recommend that you take no antioxidants during your cancer care, or that I recommend that you take, sometimes even doctors will say no supplements at all. And so I want to speak a little bit to some of the concerns around data and some of the ways to understand the data better, because certainly we would like cancer patients to be able to benefit from the use of antioxidants and other supplements during their care rather than making such a broad statement about use. And so the first challenge we have is the meaning of the word antioxidant. And that might sound like a pretty straightforward thing, but often it's not. As an example, many studies refer to vitamin A as an antioxidant, and many other studies state that it isn't. It's a subject of debate. Secondly, we discussed the issue that antioxidants can have effects on the body that go beyond their antioxidant mechanism. And so it can sometimes, looking at the research, be hard to piece out what is due to the antioxidant and what is due to some other element of behavior like vitamin A's steroid effects, vitamin D's steroid effects, or perhaps melatonin cytokine modulating effects. The other two issues that come up are study design and also the size of the studies. Going in a little bit more detail on the size of a study, you'll hear your doctor talking about the concept of study power. And you probably heard the phrase strength in numbers. Well, the bigger the study, the more powerful it is. And a powerful study is one that is able to detect an effect. So if taking a vitamin A supplement would make 100% difference in the result, well, in order to see that, we could find that with a pretty small study, a number of people enrolled. But if it makes a 5% difference, well, in order to detect that 5% difference, we're going to need to design a very large study. We're going to need to enroll thousands of people. And you'll see everything in between. Of course, research is expensive to run, and the more participants that you have, the more costly it is. And so a scientist's goal is to figure out how many people they need to answer their research question and then enroll that number of people, but not many more. And so that's when you look at studies and they'll talk about this study being powered to detect, say, a 25% improvement, that's what's going on there. And so this quote here from the Journal of the National Cancer Institute notes that one of the challenges with many studies that look at the question of antioxidants and chemotherapy is that they weren't powered to answer the question. That is, that they didn't plan to enroll enough participants to answer questions like, does this antioxidant help people live longer? Does it make the chemotherapy more or less effective? And that is a very valid concern in interpreting the research. The next concern that comes up relates to study design. And ideally, in looking at studies, the very best design is one that defines the question quite narrowly and clearly. And so it may look at a question like, in women with stage 4 metastatic breast cancer receiving solely adriamycin as their chemotherapy, does CoQ10 make the chemotherapy more effective? That would be a very narrow question. What we often see in research, though, is very broad questions like they'll take populations of people with 6 different cancer diagnoses, and they'll be on 3 different chemotherapy regimens and be given a combination of a couple different antioxidant supplements and then try to look at results. And you can imagine how challenging it is for you and your doctor to answer a question using that kind of research. So those are some of the data concerns that many scientists and physicians have. The next set of concerns related to the use of antioxidants in chemotherapy has to do with non-antioxidant mechanisms. And I'll give you a couple of examples just to make that a little more vivid. We've all heard about green tea and its wonderful benefits as a cancer preventive, and also for certain kinds of cancers, its anti-cancer effects in terms of decreasing blood vessel development in tumors, which is called anti-angiogenesis. Also in terms of helping tumor cells to self-destruct, which is called apoptosis. Those are all wonderful things about green tea, and for that reason, many cancer survivors do drink green tea. And so a study recently came out looking at a specific new medication that's given for a cancer called multiple myeloma, which is a cancer of the bones. And what they found was that this was for both a cell study in vitro, and then they also continued it as an animal study with rats. And what they found was that when they combined green tea and this particular drug called bortezomib, that the green tea made the bortezomib not work. And it was a beautifully designed study because they compared it then to some drugs that were very similar to bortezomib except for one minor difference in the drug design. And so they were really able to zero in on the fact that green tea specifically interferes with the mechanism by which bortezomib destroys cancer cells, that it's not related to any other activity of the green tea. So it's not that we have to be concerned, for example, generally about antioxidants and bortezomib, but it's specifically the behavior of the green tea that's of concern. So that's a non-antioxidant mechanism. Another example relates to the use of high-dose folate and a chemotherapy called Xeloda. And Xeloda actually works by blocking folate metabolism in tumor cells. So this is a non-antioxidant activity. And folate given at higher doses can increase some of the side effects associated with Xeloda. And some of these side effects can be quite significant. To give you some examples, hand-foot syndrome is a condition where the skin on the hands and feet peels off and can be very painful or lead to infection. Another side effect relates to the GI system, diarrhea, constipation, quite severe. And so as you can imagine, we certainly would not want to increase the toxicity of this medication. And so for that reason, many naturopathic oncologists would advise limiting supplemental folate dose usage in patients who are on Xeloda. And then finally, melatonin, as an example, is something that is quite effective and safe in helping people in fighting a variety of cancers. However, we have evidence to suggest that it may promote the growth of certain blood-borne cancers such as leukemia and lymphoma. Those are cancers of the immune system itself. And so there are times when it would not be beneficial to give melatonin to somebody who's a cancer thriver. A little bit more on concerns in relation to antioxidants and chemotherapy. Is the issue. There's been some new research that's come out regarding how the body takes the chemotherapy medicine and gets it into the tumor cells. And at the level of the tumor cell membrane, there are some pumps they work to bring nutrients into the tumor cell, and they also are what can bring chemotherapy into the tumor cell. So as you imagine, you want those pumps working in order for chemotherapy to be effective. And what we found is that when those pumps don't work well, that what we produce is tumor cells that are resistant to a broad variety of chemotherapies, which is certainly not desirable because it limits both outcomes and patients' treatment options. And what we found is that with certain chemotherapies, that some antioxidant natural products, and I've listed some of them there for your reference, can interact with those drug transport pumps, and so would not be a desirable thing to combine with those specific chemotherapies. And these are times when, for example, consulting your naturopathic oncologist or your oncologist can be beneficial because, as you can imagine, some of this cell biology gets a bit complex. So we've reviewed the benefits of combining antioxidants and chemotherapy, and as you've seen, the benefits are quite extensive. We've also reviewed several of the concerns and the strong data behind those concerns. So that brings up the question as to what do we do? How do we get the benefits of antioxidants during cancer treatment while minimizing the risks? And so I'll talk with you about safe use and 4 simple principles to guide you. I call them the 4 no's, the things that we need to know in order to proceed safely. The first thing is to know the chemotherapies that act via oxidation so that we can safely work around that. The second is to know the interactions that take place via liver metabolism, and we're going to go into great depth on liver metabolism because that's very important to understand when we combine antioxidants and chemotherapy. The third item is to know the impact of dose timing. And we'll talk about how when you take the dose of your antioxidant can make all the difference in safety and efficacy. And then finally, knowing when and how to ask for help. So this talk will empower you to use antioxidants effectively in many situations. There will be some circumstances in which it's beneficial to seek a professional opinion, and we'll talk about what those are. So first of all, know when a chemotherapy is acting through an oxidative mechanism and may have issues specifically with antioxidants. And I give you here a list of the chemotherapy drugs that in particular are known to act primarily by oxidizing tumor DNA. And at the top you'll see a clipping from an article from the Journal of the National Cancer Institute. And it notes one piece of good news regarding this issue, which is that chemotherapy oxidation of tumor DNA is very rapid acting. It happens on the scale of milliseconds after the chemotherapy is administered. And then after that, there's a DNA repair process that happens, and the way that chemotherapy works, of course, there is that normal cell DNA can repair itself over a course of the following 6 hours, and that tumor DNA will not repair and then will get destroyed by the immune system. And so many naturopathic oncologists would advise their patients then to work around this issue by considering holding antioxidants on the day of chemotherapy unless there are specific clinical trials showing safe use. And we will talk about some particular issues there where there is safe use on the day of chemotherapy. But if you're not sure or you don't know, my advice would be to consider holding it on the day. Now, for a lot of my patients, this is actually good news because for most people receiving chemotherapy, the day of their chemotherapy infusion, they want to really just focus on that and on being as well as they can going through chemotherapy. They might feel nauseous or a bit fatigued and not really feel up to taking their supplements anyways. And so I invite them to, both for their wellness and for how they feel, to consider taking a holiday from their antioxidants on that day. So we've addressed the issue of oxidation, and you can see how manageable that can be. The next thing we need to address in some depth is the way that chemotherapy is metabolized. And we have a liver there holding up a stop sign for us, asking us to stop and take a moment, set down our antioxidants, and really take the time to understand chemotherapy metabolism before choosing to take natural medicines along with chemotherapy. And so that's what we're going to do in the next few slides. Chemotherapy can be metabolized in many places in the body by the liver, the kidneys, or sometimes not even metabolized at all. For example, the drug Olimta passes straight through the body without any sort of metabolic change. And we're also going to talk about how to look up how long the chemotherapy stays in the body so that we can work with dose timing to our advantage. And regarding liver metabolism then, we want to talk a little bit about phase 1 and phase 2. You may have studied up on this a bit when learning about detoxification. And phase 1 works on making the chemotherapy water soluble. It also activates some chemotherapy drugs. That is, that the chemotherapy that you may get in the IV infusion may be inactive, and the phase 1 actually creates the active drug. So as you can imagine, we certainly want phase 1 working well. We wouldn't want to block phase 1 and then lead to not having an active drug. Of note with phase 1, though, you'll also see that it can make certain substances more toxic. And so we want to regulate the activity of phase 1 so that it doesn't get moving too fast. Then phase 2 involves glutathione, and this is where the body detoxifies those toxic compounds from phase 1 and gets them ready for excretion by the body. And we're going to go into a little bit more depth in glutathione, both the good news and the challenging news regarding its use in chemotherapy when we talk about phase 2 metabolism. So first, talking about phase 1 enzymes. Phase 1 in the liver involves liver enzymes such as the cytochrome P450 system. Each liver enzyme has a specific name that's a set of numbers and letters, and that liver enzyme will metabolize specific foods, drugs, and also body products, and by those I mean just things that the body produces. So for example, just to give a name to one of the more common ones is cytochrome P450-3A4, and it metabolizes many chemotherapies, a variety of antioxidants, particularly herbs, and even some food products like garlic. Phase 1 enzymes, their activity is constantly changing, and some of the antioxidants that we might want to take can impact phase 1 activity. And it can do that in a couple ways. One is that it can compete for binding. So you've got some chemotherapy in your bloodstream, and you've also got a particular vitamin or herb, and they are competing for that binding site. That's a fairly straightforward form of interaction. One that's a little bit more complex involves, say, for example, that the vitamin A that you take, or the vitamin E, goes in and gives the liver DNA some instructions to make more of a particular enzyme. That's called induction. And then when you have more of those enzymes, you can imagine the phase 1 works faster. And so, for example, natural products like grapefruit juice and St. John's wort act as enzyme inducers. And enzyme inducers will tend to have very broad effects on chemotherapy metabolism and are things that we may need to be more cautious with than we would be with a competitive inhibitor. And so what are the effects of modulating phase 1 enzyme activity? Well, if you induce or block an enzyme, it can change the effective dose of the drug that gets in the body. Remember, it's the effective dose, not just the dose that's put through, say, the IV or the pill, that really makes the difference. And if you lower the effective dose, the chemotherapy can become less effective. If you have a higher effective dose, then there's a higher risk of side effects. So we have a pretty narrow, what's called a therapeutic window to go in between having enough chemotherapy for it to work and not having so much that we get serious side effects. So many of my patients they're smart folks, and they think, well, hey, couldn't I leverage this situation? What if I combine my chemotherapy with an enzyme reducer and then take a lower dose of chemo? Couldn't I get great effects and less side effects that way, and maybe even save some money? And so, for example, they'll ask about taking grapefruit juice along with their chemotherapy. Now, in theory, this should work. It's a brilliant idea. There are, though, some practical challenges in terms of application in determining safe and effective doses of the chemotherapy if you were to do this. One relates to what we call the narrow therapeutic index of chemo, and we talked about that earlier, the fact that there's this narrow little window between the dose that works and the dose that hurts. The next issue is that liver enzymes have biological variability in how they work, and so it would be difficult to know exactly how a given dose of chemotherapy plus grapefruit juice would act in an individual person. You may have read about the concept of SNPs, or single nucleotide polymorphisms, that can occur in liver enzymes, so that each of us are truly individual in how our livers metabolize medications and nutrients. And that's something that's really cutting-edge science right now. Your naturopathic doctor can, for example, do some functional testing with you that can look at some of that SNP activity, and that can guide dosing and dietary choices both for cancer prevention and for cancer survivors. Next issues that come up are the variable activities of natural products. As you can imagine, one batch of grapefruit juice may be very different from another batch in terms of its enzyme-inducing capacity, and so would not be a reliable way to structure your chemotherapy dosing. And all of these factors together produce an unknown circulating net dose in the body. Recall, the net dose of chemotherapy is what's going to determine both efficacy and side effects. And we really currently don't have ways of measuring that dose in the body either, so it would just be a guessing game. And then finally, we lack clinical trials structured on this sort of idea to guide that dosage. When your oncologist recommends a specific dose of a chemotherapy drug, that's done based on clinical trials called dose escalation trials that look at the question of what is the safest and most effective dose. And so we really want to structure a chemotherapy regimen in a way that as close as possible mimics the way those trials were run, so that we know that what we're working with is a safe and effective dose. And I want to pause for a minute and invite people to type in their questions as they come up. I'm happy to speak to questions both during the talk and at the end of the talk. Most questions I'll answer at the end. However, certainly if there are some things that are unclear or that I need to explain in more detail, please type those in and let me know. So we've now discussed the issue of metabolism, and we come to the question of, well, what do we do with this information about metabolism? And so there's a couple of things that we can do. One is to research and really know that a given herb, drug, and nutrient combination is safe and effective prior to taking it. And you can find that out and know it either by researching on your own, and this talk will give you some of those tools, or certainly, particularly in complex or personalized cases, strongly encourage you to consult with your physician team, with your naturopathic oncologist to know and be confident that a combination is working well for you. Now, the other thing that you can do is to consider timing the dosing of your antioxidants to maximize benefit while avoiding interactions. And I'm going to give you the tools tonight on how to do that. And so regarding dose timing, we talked about with the oxidative mechanism, the fact that that's a pretty simple one to work around, both knowing the drugs that act oxidatively and then also holding the antioxidants just on the day of chemotherapy takes care of that pretty quickly. Then the other thing we'll look at is liver metabolism, and to do the dose timing with that, we need to understand when the chemotherapy is going to be excreted by the body, and then we can use and enjoy those antioxidants on the days that the chemotherapy would not be in the body. And just wanted to speak to the audience and thank you for all the excellent questions that you're typing in right now. I'm seeing many wonderful specific questions regarding the use of antioxidants in chemotherapy, and I'll be able to speak to those at the end of the talk. Now we're going to continue on and talk a little bit more about liver metabolism and dose timing. And with dose timing, the key concept to understand and know how to look up is called a half-life. And I know that's a very strange term, but what it means is when will half of the substance be cleared out by the body? And what we've discovered is that after 5 half-lives, the drug is 99% gone from the body. And so we're going to talk about that and how to look it up and how to use it to guide your dose timing. And I'm going to start by giving you an example. There's a drug called Abraxane. It's used in advanced breast cancer and also in lung and pancreatic cancer. And we're going to work together to look up the metabolism of Abraxane and understanding its half-life. And so an excellent tool for doing that, there's a wonderful online tool called Hippocrates. It is free to sign up for it, and once you register, you'll have access to a wealth of information about medications and their pharmacology. And you can see on the slide there's a highlighted section we're going to go into depth on, and that section tells us about how the liver metabolizes this drug and also shares with us the half-life or the time that that drug is in the body. And so in the particular dose timing example, we're going to look at paclitaxel. This is commonly given every 3 weeks. And we're going to look at an antioxidant juice blend that contains ginseng, garlic, and grapefruit. And I want to share with you that all of these natural products and this medication all act through the liver cytochrome P450-3A4. And so what we want to do is figure out, well, how can we enjoy the benefits of this juice drink and the benefits of the chemotherapy without the two of them competing for activity on cytochrome 3A4. And so we look this up in Hippocrates, and we do find here that Abraxane does go through 3A4, and that you'll see that it says under excretion, it says half-life of 27 hours. And so we know that after 5 half-lives, 99% of a drug is removed from the body. And so we take that 27 hours and multiply by 5, and we get 5 days and 10 hours. And so what that means is you can take the juice, that your buffer time after your chemotherapy is going to be 5 days and 10 hours, or we'll call it roughly 5 days, that you wouldn't drink the juice. So that's after. Now the question comes of before. Well, that has to do with the excretion time of the juice. And you can look that up for specific natural products using databases like PubMed. I can tell you that for most natural products, especially for water-soluble rather than fat-soluble ones, that they're going to be excreted out of the body within a day. And so with this juice mix, it would be safe to say that you could enjoy the juice throughout the weeks and hold it from 1 day before taking the paclitaxel through about 5 days afterwards, and that would be a safe way to get the benefits of things. And see lots of great questions coming in. Please keep them coming, and we'll have a lively discussion at the end of the talk. So when to use dose timing. There are several situations where dose timing can be an asset. One is when there is a known potential for interaction, as we discussed with the ginseng drink mix and the paclitaxel. Another would be if the interaction potential isn't known yet. Perhaps you haven't had the time or the resources to look it up, or you're having a hard time getting straight answers from your oncology team. If you're not sure what to do, dose timing would be a very safe way to go. And the other time would be if you just want to avoid having to research some of this more complex information, and perhaps you're not working with a naturopathic oncologist who can really be an asset in guiding you through some of these issues. And so now we've successfully looked up the metabolism of chemotherapy, and now we want to look up the metabolism of the natural products so we know what antioxidants can we use with a given chemotherapy. And so I'm going to give you some resources to start with, and then also some more places to look things up. And so some of the main cytochrome P450 interaction examples that we know, multiple cytochrome interactions with the herb St. John's wort and also with grapefruit juice. And so those are things that frequently when patients are taking chemotherapy or taking a lot of medications that we would use caution with. Now cytochrome P453A4 is a liver enzyme that a variety of chemotherapies and natural products go through, so it's beneficial to be familiar with. And there's a list here for you of some of the natural products that go through there. And it should say grape seed, not grape deed. There's a little typo there, but hopefully you'll know what I mean. And then garlic's interesting. It also goes through cytochrome 2CE1, which is one used by the chemotherapy dacarbazine, which is used in malignant melanoma. So those are some examples to get you started. There are certainly many more that you can look up on PubMed. And so for more detail or more personalized information, I'll give you a web link here for some excellent clinical reference guides available from Bastyr University of Naturopathic Medicine. And then also resources for consulting a naturopathic oncologist if you'd like more personalized information. That website is for the Oncology Association of Naturopathic Physicians, which is a group of naturopathic oncologists available throughout the country and in Canada to help people on their cancer care journeys. And so I'd like to conclude with some comments about phase 1 metabolism before we touch on phase 2 and dig into the glutathione controversy. So concluding with phase 1 metabolism affects direct interactions between chemotherapies and antioxidants occurring through liver enzymes. Next in the liver, we want to look at phase 2 metabolism. And you'll recall that phase 2 is the step when the liver takes the things that in phase 1 have been made water soluble but often more toxic, and the liver is going to take those, bind them up with amino acids using glutathione, and detoxify them and ready them for excretion both through the intestines and also through the kidneys. And so many people have gotten interested in glutathione and are looking at its benefits in relation to cancer care. It looks like a couple people are asking for the website, so I'm going to back up a slide and show that again for a moment. And we'll just stay on this slide for a moment. And And certainly these slides will be available to you after the talk. Dr. David can work with you as far as availability of handouts and things like that so that the slides will be available for your reference in the future. I'm going to hold it here for just a moment more, and then we're going to dig into phase 2 metabolism and glutathione. Okay, has everybody got the website okay? Okay, we're going to move on. Okay, so now we're looking at glutathione and chemotherapy. There are certainly many benefits to cancer fighters and in terms of using glutathione. So glutathione increases phase 2 metabolism, which we talked about as being the part of liver metabolism that helps to detoxify all those toxic phase 1 compounds and also supports then the excretion of chemotherapy. And glutathione and modulation of phase 2 metabolism can help to protect us from sort of self-toxifying through an overactive phase 1 metabolism. And so we talked about, for example, in phase 1, those enzyme inducers. So if we have enzyme induction, particularly petrochemicals and polycyclic aromatic hydrocarbons from air pollution can hyperactivate phase 1 and create more self-intoxication. And so glutathione can balance that in phase 2. Those are wonderful benefits. Glutathione also supports genetic repair of damaged healthy cells, which can be precursors to cancer cells. And also glutathione with certain chemotherapies has clinical trials to support the fact that it can decrease side effects without decreasing efficacy. And that's particularly for oxaliplatin and neuropathy. And to give you an idea, some of the hospitals that I work with have it as a standard practice now that glutathione is given IV during chemotherapy with oxaliplatin because the evidence is so clear there. There are also some significant concerns with the use of glutathione in some chemotherapies, and we need to understand those in order to use glutathione safely. One of the concerns is that it may protect tumor cells from chemotherapy, and the potential consequences of that would be decreased effectiveness of the chemotherapy and development of drug resistance. And we're going to dig into that in a little more depth now. This image here shows you a picture of a tumor cell, and you can see in there with the arrows there are some pumps, and there in the middle I'm going to draw an arrow for you now. Oh, wrong way. Let me turn that around. Okay, so the arrow is pointing here on a little acronym there that says MDR, and MDR stands for multi-drug resistance. So we spoke at the beginning of the talk at how cancer cells are different from normal cells and that we need to really understand and respect this in order to care for people who are fighting cancer. And one of the ways that cancer cells are different is that they're smart and they use these pumps in their cell membranes to get rid of the chemotherapy that's trying to destroy them, and that's what the multi-drug resistance pump does. Now, what fuels the multi-drug resistance pump? Well, one of the main fuels for that pump is the activity of an enzyme called glutathione S transferase here. And you can see that in the diagram here. And so glutathione S transferase is actually referred to as a multi-drug resistance protein, and increases in tumor intracellular glutathione are actually linked to chemotherapy multi-drug resistance. Now, I'm trying to be clear here, speaking of tumor and intracellular, because those are sometimes more specific than, for example, the glutathione that is made by the body in the liver and is not in the tumor if you don't have tumors in the liver. And so speaking a little bit more about the evidence regarding glutathione and chemotherapy, it's found that those multi-drug resistance transporters and those tumor glutathione transporters are involved in copper metabolism, that activates chemotherapy resistance with the platinum family, which is interesting and also makes sense from the perspective of both being metals, copper and platinum. Also, tumor glutathione increases are associated with activation of NF-kappa beta, which is an inflammatory product that stimulates tumor growth in a variety of cancers. And we'll talk about this more in my next talk with Building Strength webinars, where we talk about research from MD Anderson scientists that find that 90 to 95% of tumors may be preventable. which is very exciting news. And those researchers are really digging in depth with NF-kappa beta and its activity in fueling tumor cell growth and talking about how natural medicine can intervene with that. So very exciting news there. Furthermore, on glutathione, we find that natural agents that decrease tumor intracellular glutathione are linked to an increased effectiveness of chemotherapy. Some of those natural agents include a mushroom called agaricus and an herb called dongquai from China. And so naturopathic oncologists are really looking closely at using the decrease of tumor intracellular glutathione as a desirable therapeutic target in cancer care. And so some of our conclusions when we look at phase 2 metabolism are the fact that, first of all, that there are natural products that can increase glutathione, and we don't yet know for certain that those would impact tumor intracellular glutathione, but we certainly have reason to be concerned. And some of those natural products are, of course, glutathione itself, also N-acetylcysteine, called NAC, high-dose cysteine alone as an amino acid, and alpha-lipoic acid. Now, we can use these confidently with chemotherapy when there are good clinical trials to support it, as with the case of glutathione and oxaliplatin that I spoke of earlier. Otherwise, we probably should exercise caution when it comes to combining glutathione and chemotherapy, and that's where that half-life-based dose timing can come in and help us. And in that way, we get the benefits of glutathione and phase 2 support while avoiding the risks of potentially protecting tumor cells from chemotherapy and even generating the very dangerous condition of multi-drug resistance. So we've talked then about phase 1 and phase 2 metabolism, and to close up our conversation about liver metabolism and chemotherapy, one of the things that we need to do is understand the data a little bit more. And a lot of my patients get understandably frustrated when one research study will say that a particular antioxidant works just great with their chemotherapy, and then another study finds problems, and they wonder, how do they make sense of all this? And it is difficult, and one of the things that helps is to understand the different kinds of evidence, because when evidence is contradictory, often it's a contradiction between a weaker study and a stronger study, and then if we know which one takes precedence, then that can guide us. So the weakest studies, and the ones that you'll actually hear the most about in the news, even though they're fairly weak, are the in vitro or cell studies. These are great for generating ideas for further research or things to maybe be aware of or concerned about, but they're not really strong enough to completely guide clinical practice. Moderate strength would be population studies, looking like epidemiological studies or animal studies. And then the strongest data comes from clinical trials or what are called drug tracer studies, and we'll talk about that in more detail. And so a drug tracer study is where they'll give a natural product along with a drug that's known to modulate a specific liver enzyme. And with that way, they can answer the question of, does this particular natural product act on a given liver enzyme? Moderate evidence then would be animal studies. And so, for example, the one I spoke to about green tea and bortezomib was actually an animal study. And then other forms of moderate evidence would be population studies, epidemiologic studies, like, for example, the recent one that came out about green tea and breast cancer, and also case reports of potential interactions. Then the weakest or most preliminary evidence are the cell studies. And really the purpose of these is to generate ideas for further research, and then we look to the animal and human studies to confirm or refute that data. And so, for example, for a long time, the understanding was that milk thistle should not be combined with chemotherapy, and that was based on in vitro studies and some animal studies. And then new data came out from a drug tracer trial, which found that there actually may be no concern with milk thistle, and particularly the cytochrome 3A4. And so for that reason, many naturopathic oncologists advise their patients that it may be okay to combine milk thistle with chemotherapy. Typically, with that guidance, they'll explain the evidence to the patient and to their oncologist, and so everybody's on board knowing the evidence, the risks, the benefits before making a decision. So we've talked about 3 things to know so far in combining antioxidants and chemotherapy. We've talked about knowing oxidative mechanisms. We've talked about knowing dose timing. We've talked about knowing liver metabolism. And the 4th thing to know is when and how to ask for help. Certainly, based on the questions that are coming in, some of you are experiencing the fact that this can be a very complex topic. And so there are certainly things that can be safe to do on your own, and I hope at the end of this talk that you'll feel empowered to get your antioxidants by eating whole foods, knowing that even as you're going through cancer care, that this is an effective and safe way to get the benefits of antioxidants. I also hope that you'll feel confident using dose timing of your supplements in relation to chemotherapy in order to enjoy the benefits of antioxidants, and that you'll also feel confident understanding the impact that smoking can have on antioxidant safety. I also would encourage you to know when to ask for help from a professional. And some of those circumstances would include, one, that you are currently receiving chemotherapy and you'd like to take some high-dose, concentrated antioxidant nutrients or herbs and want to know what's safe and effective. And it can be good to ask for help in this circumstance because, as you may have discovered in this talk, there are many different methods through which antioxidants and chemotherapy can interact, both for harm and also for benefit, and you want to maximize those to your advantage. Other times to seek help might be if you're taking a multi-drug chemotherapy. So, for example, one of the participants wrote in asking about combinations of nutrients with a chemotherapy set called CMF, or cyclophosphamide, methotrexate, and 5-FU. Now, there are very complex interactions that happen when you take 2 or 3 or even 4 chemotherapies together, and that's where professional guidance can be really beneficial and go beyond the scope of what's possible in an educational talk such as this. And then finally, times to know when to get help would be when you'd like to have more personalized guidance based on your particular situation and needs. For example, many of the patients that I consult with have complex or advanced cancer cases. They may have been through extensive prior chemotherapy and radiation and surgery, or they may have complicated comorbid conditions such as diabetes or chronic heart disease, and so, or be on multiple medications in addition to their chemotherapy. And those are really times when it can be beneficial to work closely with your oncology care team and your naturopathic oncologist in order to get the best results, really going above and beyond what can be achieved through personal education and that beneficial empowerment. And so we talked about the 4 no's, and we now have some conclusions on safe use, which are that it's beneficial to understand chemotherapy and natural product metabolism prior to combining antioxidants and chemotherapy. And we can then confidently interpret data based on the strength of the evidence, leaning more heavily on clinical trials and drugs tracer studies than we do, for example, on cell studies. If metabolism information is not available, then we can use dose timing to avoid interactions, and we can know when to consult expert guidance for more personalized information. And so, in conclusion with the talk, I want to speak to the fact that antioxidants can be used safely and effectively with chemotherapy. The most foolproof and nourishing source for those antioxidants is your whole foods. And I encourage my patients to know that supplements are really that. They are supplements to a whole food nourishing diet and not a replacement for them. And then prior to consuming concentrated antioxidants in the form of supplements, we can know how to research the risks and benefits in relation to chemotherapy treatment. And if unsure or if the data is unclear, to consider using that dose timing strategy with the 5 half-lives to avoid interactions. And I hope that this talk also empowers you to communicate about supplements with your oncology team, encourage you to take copies of some of the studies that were cited, like the Simone review, and take those to your oncologist and talk to them about the data. And then, when needed, to consult with a naturopathic oncologist for personalized guidance. And also, to further empower you in your journey in cancer care, I want to encourage you to join us for our next talk, where we'll talk about the fact that cancer is preventable. So many of my patients get concerned or lose hope over hearing the news that cancer is pretty much all genetic. They'll often hear that from their oncologists. And some wonderful scientists at the prestigious MD Anderson Cancer Institute in Texas looked at this issue, and they found that 5 to 10% of all cancer cases were truly related to heritable genetic conditions, whereas that 90 to 95% of all cancers were related to lifestyle factors that are preventable. And so in this talk, we're going to explore that data in depth and help you discover what you can do to protect your family from cancer. And so finally, I want to offer you some resources where you can get more in-depth information. On my website, which is newpath2health.net, I offer e-health tips on a variety of conditions, cancer, and also a variety of other chronic diseases. There's a searchable archive so that you can find out things that may be more specific to your situation. And there's also a way that you can sign up to receive news feeds as new information comes out. Those are available both through RSS feeders like Google Reader if you use that, and also through Facebook. And then we've talked about some of the benefits of working with a naturopathic oncologist, and there's a website there called oncamp.org that is your link to finding a qualified naturopathic oncologist in your community. And so now I want to speak to the questions that you sent in and invite you to please send more questions, and we'll be sure to discuss all of those. So thank you so much for joining us, and I hope that this talk has been valuable for you in your cancer care journey. And so now I'm going to take a moment to look at the questions and speak to some of those. And so one participant asked a little bit about modified citrus pectin and its role with chemotherapy. And modified citrus pectin is a wonderful tool. It binds to galectin receptors on the surface of tumor cells that control the ability of a tumor cell to bind to tissue. And so, for example, a lot of naturopathic oncologists use modified citrus pectin, particularly around the time of cancer surgery, to address the issue of any stray tumor cells that might get loose during a biopsy or surgery as a protective mechanism. To my knowledge, there aren't any significant interactions between modified citrus pectin and chemotherapy. Certainly, the data is always updating and changing with those issues, but that's my knowledge at this time. An important thing to understand about modified citrus pectin is situations when it's most beneficial, which is, first of all, more so in early stage cancers than in advanced cancers, because in advanced cancers they stop expressing the galectin receptor. It wouldn't harm a person to take modified citrus pectin in that situation, but it may not be of benefit. And then also, modified citrus pectin is specific to cancer types. Some of the cancer types that most express the galectin receptor are breast cancer, prostate cancer, and ovarian cancer. So I hope that speaks to the question on modified citrus pectin. Another question came in about the safety of taking CoQ10 and vitamin C during CMF, and I spoke earlier about some of the particular challenges related to multi-drug chemotherapy regimens. To my knowledge, those are safe items to combine with that chemotherapy. Certainly, if the patient were getting radiation therapy, there's some extra complexity there with dosing of CoQ10 and safe doses to use with radiation. Another thing to keep in mind related to that when we're talking about safety is to understand that there are often co-medications that come with chemotherapy. There may be steroids or antihistamines, for example, or growth factors like Neulasta that are given alongside your chemotherapy that you may not even be aware that you're getting, because they'll just go right in your IV bag. And so when your naturopathic oncologist looks at these safety questions, she's going to look not only at the chemotherapy like the CMF, she's also going to have to look at those co-medications as well. So let's see, we spoke to that question. There's a question about, does melatonin improve lung function without a cancer diagnosis? I'd have to dig deeper into the data on that one. I believe I've read some studies that melatonin increases lung function in chronic obstructive pulmonary disease, for example, but again, I'd have to brush up on the studies to speak to that question. And let's see, Mary writes in asking about oral vitamin C and a concern regarding it feeding cancer cells. And I think where that comment may be coming from is the perspective that vitamin C has what we call a biphasic effect, where vitamin C below a certain dosage is an antioxidant, whereas vitamin C above a certain dosage is a pro-oxidant. And so, for example, the vitamin C that you take orally and get through food is going to act as an antioxidant, whereas the vitamin C given in an IV vitamin C, for example, where you get on the order of 20 to 50 milligrams, 20 to 50 grams in a single dose, is acting as a pro-oxidant. Now, regarding the concern of it feeding cancer cells, I would say quite the opposite. In fact, acting as an oxidant or pro-oxidant, that vitamin C can damage tumor cell DNA, has anti-cancer effects. Some researchers at the University of Kansas are looking at this question specifically in clinical trials right now, and there's many preliminary research studies that have been done by a research center called the Bright Spot for Health out of Kansas, Dr. Reardon's lab. So I'd encourage you to look into that, Mary. And furthermore, there's also research regarding vitamin C happening at the University of Kansas, the pro-oxidant question, looking at how vitamin C may act to bind up tumors, that specifically it increases the body's expression, of course, of connective tissue building and may help to then wrap the tumor in connective tissue, walling it off and preventing its growth. So I think there's very positive research there with high-dose vitamin C, but it really does have to be administered intravenously. Some doctors have looked at the alternative of high oral doses. What they found is that the gastrointestinal tract does shut off absorption at a certain point, and pretty much what you'll get beyond that is loose stools. Now, that's certainly beneficial for many of my cancer patients who are constipated by their pain medications or by their chemotherapy or their antiemetic drugs, but you're not going to get the vitamin C benefit there. The other issue with trying to do high-dose vitamin C orally, some doctors are marketing liposomal products, and certainly that's physiologically interesting and promising research. What many of my colleagues are finding is that they give that liposomal product and then they're testing vitamin C serum levels, and the serum levels are just not coming up to the point that would be needed for oxidative benefit. And so at this time, our understanding is that to get that oxidative benefit with vitamin C, that you really need to do it intravenously. And Gloria writes in asking about smoking and antioxidants and some clarity there. And she asks a question, do I mean that all smokers, not just those with cancer, should get their antioxidants from only food and not from supplements? And the honest answer to that, Gloria, is that it's an excellent question and we just don't know. As part of the core principles of naturopathic medicine, I took an oath to first do no harm with patients. And so I tend to err on the side of caution, especially when good benefits are available in other ways. And this is something where, for a current smoker, getting antioxidants from whole foods is just a win-win, because smokers have a greater need for cancer-fighting benefit than non-smokers do, generally speaking, and whole foods are going to provide those extra micronutrients. They're going to give you that cancer-fighting benefit, like we talked, for example, about the sulforaphane and its activity on cancer stem cells. Well, if you're taking your antioxidants in pill form, you're just not going to get those micronutrients. In my next lecture, when I talk about the preventability of cancer, I will speak to that more as far as a variety and diversity of anti-cancer compounds that are available in whole foods that just go far beyond the scope of what can be done by taking pills. And so certainly looking at the data, a variety of positions could be supported. My advice to patients who are current smokers is to focus on their whole foods if at all possible. And then Paula writes in asking about, does the drug Gemzar used for pancreatic cancer fall into some of the categories I discussed, like the platinums and anthracyclines? And no, it does not. Gemzar is sort of out on its own as a drug. And that's based just on my knowledge off the top of my head, Gloria. Certainly before guiding a patient on, Paula, on those issues, I do always double check things because, as you probably gathered from this conversation, oncology care is quite complex. And so whether you're a patient who's going through cancer or even a healthcare professional, personally I find that before giving somebody advice, I always double and triple check my data just to be sure. And so if I were speaking to a patient about that question, Gemzar in this issue, I would look that up and just double check its metabolism. And then Howard writes in asking about anti-cancer effect with chocolate and grapeseed extract and how they've been used. Chocolate's been studied particularly with skin cancers and has been found to decrease UV damage, particularly the UVC damage that is known to progress skin towards melanoma. And so some very promising things there. Grapeseed extract has some promising in vitro research as far as anti-cancer effect in prostate cancer in particular. Also has some very interesting information many of my colleagues are finding benefit with grapeseed extract in terms of hot flashes for prostate cancer patients. Now, you may have seen in one of the earlier slides that high-dose grapeseed extract does modulate cytochrome P450-3A4 activity, so we need to be cautious there. So, for example, in my prostate cancer patients, I would look at what they're taking. Some of them are going to be on periodically dosed medications like Lupron. There we have some more room to work with grapeseed, where some of them are on a daily medication like Casodex that it does go through 3A4, and there I would consider alternatives to grapeseed. Let's see. What other questions do we have here? There's a question about curcumin and chemotherapy related to colon cancer, and that's a great question. Curcumin is very valuable in relation to colon cancer patients. It works on stimulating apoptosis. It acts on the J and K pathway, which is very significant in promoting apoptosis. And so it's something that's very valuable for a lot of my patients fighting colon cancer. In relation to chemotherapy, it's something that we look at from a couple of different angles. One is patient tolerability. One of the main side effects with curcumin is GI upset, and that might not sound like a big deal, but for some of my patients that can be significant. A lot of my patients have comorbid chronic reflux disease. They may have cancers that affect their digestion. For example, if they have gastric cancer, that can be an issue. And for colon cancer patients, a lot of them have had portions of their digestive tract rerouted, as it were, through extensive surgery, and so that can also come up as an issue. So I first of all have to look at patient tolerability. A second issue is chemotherapy metabolism. Curcumin does modulate cytochrome 3A4, and so we would use dose timing if appropriate with the chemotherapy. There are certainly chemotherapies used in colon cancer that do not go through 3A4, and we have some room to work with it. If the patient's currently going through radiation, it's an excellent tool and even a radiation sensitizer, so we get some double benefit there. But if, for example, my patient were on Tarceva, which goes through 3A4, then we need to work with dose timing. So I hope that speaks to that question. The question of vitamin B17, also called Laetrile, that's something that's harvested from apricot pits. Currently, what I see on the research is that there's certainly some very interesting case reports as far as Laetrile and some physiologic and in vitro evidence to suggest benefit. It just hasn't really made it through to the human data yet showing benefit, and there are, I think, some valid concerns as far as the amount of cyanide that's present in vitamin B17 and naturally concentrated in the apricot pit. Certainly, if you're eating an apricot pit here and there, it's not going to make any difference, but most of my patients, if they do vitamin B17, they want to do high dose, and there can be significant issues with the cyanide dosing there. And so usually what I do for my patients then is guide them towards other natural agents that have better data for safety and certainly much better data for efficacy. So, for example, regarding the question about colon cancer, take a look at the data on clinical trials regarding a supplement called fermented wheat germ extract, or AVE, and those have very strong data in terms of increasing overall survival, increasing progression-free survival, which is the time where you're living and not having your cancer progress. And that's just got such great data and good safety, and so those are the kinds of things I steer patients towards. Enzymes relating to cancer is a really interesting idea, particularly in terms of pancreatic cancer. Dr. Gonzalez in New York has looked at that. And the data is at kind of a tough spot, which is that he did work on a phase 2 clinical trial and a phase 3 clinical trial in relation to that question, looking at his high-dose enzyme product program. And, excuse me, and the results came out and the study was stopped early because there was not a benefit. Now, Dr. Gonzalez did then publish a rebuttal to that, which you can find online, that did discuss many of the methodological concerns with how the study was run by the study organizers, and the fact that most of the patients who were supposedly in the enzyme testing group may not have actually gotten active product, and or were not, rephrase, I don't mean active product, that they were not well enough to actually be compliant with the regimen that involved more than 100 pills a day, and so may not actually have experienced it. And so I think we have to look at that question with enzymes. Other areas where enzymes can help cancer patients certainly are in pain relief, in digestion. For people with pancreatic cancer, particularly if they've had a Whipple procedure, enzymes may be mandatory even for proper digestion and absorption. And so those areas we get into with enzyme therapy as well. I'm going to step away from the camera for just a moment to get a sip of water, and then I'll be right back and we'll continue answering all of your questions. Excuse me for just a moment. Okay, and we're back, and we'll continue going through the rest of your questions. Reishi mushroom extract in chemotherapy, very good question. Can be very beneficial. It's helpful for liver support and has some good anti-cancer research, in particular in relation to breast cancer. Also beneficial with chemotherapy, good interaction in terms of potentially keeping up white cell counts going through chemotherapy so that people can keep up that dose intensity. I am not aware of any adverse interactions with reishi and chemotherapy. Certainly a caveat with this answer and with all of these answers is to understand that the data is complex and always changing. So certainly double check your situation before taking something. Next question, Marita Campbell has an excellent question about food-based supplements rather than synthetic and what's better or more beneficial. Excuse me, I'm going to take a sip of water. Food-based supplements are very interesting. One thing to look at when you look at your food-based supplement is how is it made? And certainly some quote-unquote food-based supplements are actually made by grinding up and concentrating actual foods. So for example, there's a sulforaphane supplement that I use with many of my patients that is used by taking broccoli sprouts and freeze-drying them and dehydrating them and then putting it in a capsule. And that is a truly food-based supplement, an excellent product. Other food-based supplements are used by growing a yeast culture, and then they take that yeast culture and they feed it concentrated vitamins, synthetic vitamins, and the yeast chomp on those synthetic vitamins, and then the yeast product gets harvested and made into a quote-unquote food-based supplement. That's the case for actually the majority of quote-unquote food-based multivitamins. And I think this really raises a good question about how exactly supposedly food-based something is if we're basically looking at yeast spit made from concentrated synthetic vitamins. And so I would call that out as being the synthetic product that it truly is. Now, Marita also raises a good question regarding synthetic vitamins and how that affects things, and certainly that is an issue. For example, that's come up as a significant issue in interpreting the data on vitamin E. You may have heard about there's D-alpha tocopherol and L-alpha tocopherol, and what I invite my patients to do is think about the L as being L for loser, and so the L form is a synthetic. The natural form is going to be the all-D form, and that's what you want to have. And certainly there's been some studies that have shown negative outcomes with vitamin E where they used an L-alpha tocopherol, and I think that really begs the question about whether they're testing L-alpha tocopherol, if they're testing vitamin E or just testing a synthetic product and saying it's not beneficial. So yes, Marita, you raise a very good question, and there are many examples of that in the literature that could be almost an entire talk in and of itself. Let's see, what other questions we have here. Dr. David writes in asking about good whole food multivitamin pills that would work. The Newmark and New Chapter brands do make some good things. They also do some of those yeast extracts. You kind of have to look at each product in particular. Innate Response is another product line as well that does some true whole food ones. So those are some examples. But again, look at them closely because I'm not aware, honestly, of any single supplement company that's doing purely true whole food rather than kind of a mix of whole food and the yeast products. Let's see. Katherine writes in asking about the use of zeolites while on chemotherapy and radiation, and that's certainly an interesting topic. And I'm not aware of any literature looking at the question of interaction of zeolites with chemotherapy and radiation specifically, so it's hard to answer that question, both from the potential of benefit or harm. We just don't know. What we do know about zeolites is that they are going to bind up contents in the intestine and compete for absorption. So, for example, if you're taking an oral chemotherapy like a Xeloda or a Tarceva, just as you would hold your calcium and magnesium at the time that you're taking the Xeloda and space them apart, you certainly would not want to take your zeolite at the same time that you're taking an oral chemotherapy. Let's see. And questions about calcium and magnesium and colon cancer. There is some benefit, some research as far as benefit of anti-cancer effects of calcium. Magnesium, of course, is beneficial to balance the calcium and also to help patients with a lot of the digestive challenges they have with colon cancer. A lot of my patients going through conventional therapy for colon cancer can get quite horrible constipation, both from their pain medication and their antiemetics and their chemotherapies as well. And so magnesium and vitamin C are both very valuable in regulating bowel regularity naturally as well. In terms of specific anti-cancer effects of magnesium in colon cancer, I'm not familiar with that literature, but certainly it's possible that it's out there, and I just haven't read it yet. I hope you're getting the feeling as we discuss these questions how extensive the research is in cancer and how there's just always something new and wonderful to learn. Let's see here. Deborah writes in with a question about supplements being specific to a person's body chemistry and the role of an individualized supplement program. Certainly that can be beneficial. In some cases, specific micronutrient testing, such as the SpectraCell test, can be beneficial. That's helped a variety of my patients. We can also look at metabolic individuality based on what we know. For example, things about food sensitivities, celiac disease can come into play as well. I know some practitioners have good success with muscle testing. There certainly, to my knowledge, isn't any specific research on muscle testing and supplements in cancer, but it's something that I know that some people use empirically. Some folks are asking about supplements in relation to pancreatic cancer, and that, of course, has to be targeted to the specific patient. But some of the supplements that I think would strongly be considered would include melatonin for its cytokine and interleukin modulation effects, curcumin for that JNK pathway and apoptosis effects that we discussed earlier, and green tea as well for its modulation of angiogenesis. Vitamin K has some very interesting research, as well as does alpha-lipoic acid when used in conjunction with low-dose naltrexone. And then some conversation here about decreasing meat products in the diet during chemotherapy. I think there's very good research regarding the role of meat products and cancer prevention and carcinogenesis, particularly in colon cancer. I think another good concern about meat products during cancer care relates to nitrites in meat and their production of nitrosamines, and so that's something that I encourage my patients to look out for. And certainly people who eat less meat generally eat more whole plant-based foods, which are beneficial in terms of all those cancer-preventing and cancer-fighting phytochemicals that we talked about here and that we'll discuss in the next talk. So I think it's a good thing to look at. The China study, also as in terms of epidemiological research, I think has some very interesting data regarding the possibility of certain animal products promoting tumor cell development. There's been additional data, for example, looking at the question of dairy and the fact that it contains insulin-like growth factor that may stimulate breast cancer development. So I think there's some good things to look at there in those questions. Let's see here. Vicky asks about agaricus and a product called Agara Gold. Excuse me, I'm just going to moisten my throat here. And agaricus is something very interesting in cancer. There's been some good research on agaricus, particularly in hepatocellular carcinoma, which is a primary tumor of the liver. Clinically, what I've seen is that agaricus can be beneficial in terms of modulating white cell count for patients undergoing chemotherapy. I'm not familiar with the particular product Agarigold, so I can't comment on that. I can tell you with Agaricus that there have been, with some of the products that I've previously used, some significant quality and contamination concerns that have come up, and so the use of Agaricus has become a bit more limited in my practice of late. And let's see. Hendrikus asks about liquid oxygen in cancer clinical trials. I'm not familiar with any clinical trial data on that subject. Certainly, if Hendrikus or other participants find that clinical trial data, please do post it to our site, and I'd be very interested to see that. Let's see. And then Hendrikus also asks about thyroid cancer tips. And there are several nutrients and situations that are specific for thyroid cancer. Vitamin A has some anti-cancer effect in thyroid cancer. And then in focusing on thyroid cancer care, it's something that we also have to be specific with the stage of therapy. The first standard therapy for locally advanced thyroid cancer is the radioactive iodine therapy. And so patients who are receiving that, we need to be real specific about their not taking any other sources of iodine during the time that they're going to have that testing. And then it's both a test and a treatment. And so looking very closely at their supplements, at their diet, to avoid all sources of iodine for that narrow window of time when they're getting that care is very, very important. Quercetin has some interesting research in thyroid cancer as well, so those are some good things to look at. And let's see. Scrolling down to the next set of questions. The question about the Nature's Plus line of whole food supplements. I'm not familiar with that product, so I can't comment on it. And Deborah asks about studies addressing a dramatic change of diet, exercise, and emotional well-being having a cancer elimination effect. And yes, there have been some very interesting studies done on that. For example, oh golly, his name will come to me. Dr. Dean Ornish has done some great work on that, focusing on prostate cancer and really doing a holistic approach of dietary change, physical activity, and emotional well-being and stress management all combined in one, and showing strong anti-cancer effects with that. So Deborah, I'd encourage you to look into that. Questions about Neubauer products. I'm not familiar with those, so I can't comment on that. Questions about from Vicki regarding thyroid cancer and potential increase in rates of that with environmental toxicity. Vicki, that's a great question, and yes, I do think there are some issues there. I'll point out a couple. One is radiation in the environment. Vicki, you may want to read up on the case of what are called the downwinders, particularly in the areas of Nevada and Utah in relation to radioactive testing that was done in the 1950s and radiation exposure at that time and thereafter as that radioactivity is decaying. I think we'll continue to see concerns in that, particularly as we look at disposal of depleted uranium products from military activity. I know that certain cities in the state of Utah, for example, have been accepting depleted uranium being disposed in their communities, and depleted uranium is something that continues to be radioactive for a very, very long time, and I think that we may see some greater concerns with a variety of cancers, thyroid cancer included, with that. Also related to environmental toxicities, there's the question of perchlorate. Perchlorate is something that's made as a byproduct of manufacturing rockets. There are several plants involved in that put perchlorate into the Colorado River in Arizona, and normally that might be only a concern of people who live in that area. However, Colorado River water produces the vast majority of fruits and vegetables grown for the entire United States, and so there's been some concern regarding perchlorate concentration in food. And if you check out the website of the Environmental Working Group, they have a wonderful report on perchlorate rocket fuel and the thyroid that may be of interest, looking at how perchlorate downregulates thyroid function. So I think you'll enjoy that. And Katherine writes in with another question about Dr. Simoncini and sodium bicarbonate treatment. Dr. Simoncini is looking at the theory of fungal activity as being a driver of cancer, or even at the idea that cancer actually is a fungus. Certainly a very intriguing theory. And then he's looking at the use of IV sodium bicarbonate to address this. I know that some of my colleague naturopathic oncologists are using this treatment, and some of them are discussing having good benefits. To my understanding, the data on this right now is pretty preliminary, so it's not something that I'm yet encouraging my patients to seek out, but certainly is something of interest. I am holding this data to a bit of a higher standard because of some of the safety concerns with IV sodium bicarbonate. The body does regulate acid-base balance pretty carefully. Swings to either extreme of acid or base can be acutely life-threatening. And so a treatment like IV sodium bicarbonate is something that I think we have to really ask more in terms of data on safety and efficacy before recommending than we would from something that is clearly pretty generally safe, like, for example, modified citrus pectin or fermented wheat germ extract. And Vicki writes in saying that the Environmental Working Group website has been very beneficial to her practice, that as a healthcare provider she's seen more and more thyroid dysfunction and cancer and finding it helpful. And yes, Vicki, I agree, it's a wonderful site. Some other great resources that you can find there. One relates to the role of personal care products in cancer, looking at things as diverse as makeup and shampoo, sunscreen, those sorts of things. It just breaks my heart when my patients are striving to protect themselves from cancer by, for example, using sunscreen, but maybe without knowing it are using a product that actually increases their cancer risk, or they're introducing their 6-year-old daughter to makeup for the first time, and the little girl is using a lipstick that has hormone disruptors or things that can cause breast cancer in it, and she's smearing that all over her face. And so my patients find it really empowering to have access to this information. The EWG site has a wonderful database where you can look up safe shampoos and cosmetics and things like that, and it's just a great preventive tool for your patients to really help them address the cause of some of their concerns. And for people who are interested in more things related to environmental medicine and cancer, I'd encourage you to visit my website. I have a variety of tools there written as well. And so in closing, I want to thank you all very much for participating in this talk. I hope that you've found it useful and empowering, and I look forward to continuing to communicate with all of you. Please join us for our next talk on cancer as a preventable disease, and have a good night. Blessings to everyone.